Good evening, everyone. Hello. Welcome to the next episode of Dr. Tristan's Anesthesia Tutorials. And this evening we are going to be talking about pediatric neuroanesthesia. And the first part of this episode 5 is neurophysiology relevant to the anaesthetist. So for this evening, for the next sort of 35, 40 minutes or so, we're going to discuss neurophysiology and CNS changes that are relevant to the anaesthetist. We're going to talk about it in adults as well as in children. Excuse me. And then we are going to specifically just look at some unique issues in pediatric neuroanesthesia in particular. So let's get going. So this is the overview of our talk. We are going to essentially, I'm going to give you just a little bit of an introduction. We're going to talk about cerebral metabolism. We're going to talk about cerebral blood flow. We're going to talk about CSF fluid, cerebrospinal fluid. And then I'm going to speak to you about some issues specific to pediatrics. And then we're going to talk about the anesthetic effects on cerebral blood flow at the end. So an introduction to the brain. Essentially, the adult human brain weighs around 1.5 kilograms. Okay, so that represents only 2% of total body weight. And I'm sure those of you familiar with any forms of physiology will know the stat, and it is true that even though the brain is only 2% of body weight, it consumes 20% of the body's total energy. So our brain is continuously active, even when we're sleeping, even when we're under anesthesia. There are different activating and inhibitory systems in the brain that keep us awake and make us sleep and regulate our level of wakefulness. There is tight regulation of oxygen supply and substrate, in particular glucose availability. And then there are different metabolic activities across brain regions that determine the cerebral metabolic rate of oxygen consumption, the cerebral metabolic rate of glucose consumption, and what will determine the autoregulation, so the blood flow to certain regions of the brain in this metabolic flow coupling, whereby an increase in oxidative stress, so an increase in brain metabolism, will increase blood flow to a particular area of the brain. So when we first start off and we look at oxygen and glucose consumption, the first thing that we need to be aware of is that the glucose is the primary oxygen source for the brain. The brain cannot use fatty acids, the brain cannot use amino acids, the brain can only use glucose, and then secondarily it can use ketones. Now the brain does like ketones, and that's a topic for a different day, but predominantly the brain relies on pure glucose. So the Krebs or the TCA cycle, oxidative phosphorylation and glucose oxidation occurs. Oxygen is an electron acceptor, and energy is liberated at the mitochondria, the classic normal oxidative metabolism of glucose, the aerobic metabolism of glucose. So the normal CMRO2, which is the cerebral metabolic rate of oxygen consumption, is around 3.5 mils per 100 grams of brain tissue at rest in an adult. In a neonate and an infant, that is closer to 5 to 6 mils of oxygen per 100 grams per minute. The oxygen consumption is roughly 150 to 100 micromoles, of oxygen, and you can double that for pediatrics. The normal PO2 in the brain is 25 to 40 millimeters of mercury. That is the normal range. The critical oxygen threshold is around 20 in infants and children, and in adults it's around 10. And at this point, ischemia starts to happen in the brain, and massive changes to the cerebral vasculature in the name of vasodilation will occur if the oxygen drops below that critical tension, so that blood can be brought to the brain in order to replenish that oxygen. When we look at cerebral oxygen energy production, The oxygen to glucose ratio at rest is 6:1, and the main substrate, as I said, is glucose, with the secondary substrate being ketones. Proteins and fatty acids are not metabolizable in the brain. The CMR glucose, so the cerebral metabolic rate of glucose consumption, is around 30 micromoles per 100 grams per minute, so roughly 5 milligrams of glucose per 100 grams of brain tissue per minute in an adult. And again, in a neonate, you can increase that to 10 to 15 milligrams of glucose per 100 grams of brain tissue. So obviously, they're much more susceptible to hypoglycemic injury and hypoxic injury. Just quickly, how do we measure the cerebral metabolic rate of oxygenation and metabolism? We can do jugular venous oximetry, where a oximeter is placed in the jugular venous bulb, and you can measure the oxygen saturation in the venous side so that you can then determine the amount of oxygen extraction. You can then measure directly through brain microdialysis brain tissue oxygenation tension, so you measure the PO2 in the brain tissue itself. You can then do near infrared spectroscopy, and that is basically a saturation monitor that measures a mixed venous oxygen saturation of the frontal lobe of the brain. And then you can do cerebral microdialysis, where you can sample oxygen tension, metabolism, glucose, etc. So when we look at cerebral blood flow, we need to understand the term neurovascular coupling. So what does this mean? Cerebral blood flow is roughly 800 mils per minute in the average adult. So it's roughly 15 to 20% of cardiac output. So in a child, it's about 50 mils per 100 grams of body weight per minute. So if you think of it as roughly 1/5 of cardiac output, that will be pretty accurate. In normal physiological states, there is a constant blood flow in the brain, okay? So what that means is that at a normal physiology level, where the oxygen tension is okay, the CO2 is okay, the glucose is okay, blood flow, regardless of my day, regardless of my state of wakefulness or sleep, etc., blood flow in my brain is pretty much constant, regardless of my daily fluctuations in mean arterial pressure, from posture changes, etc., etc. So what that means is that the vasculature is coupled to the oxygen consumption, meaning that the more active an area of brain becomes and the more oxygen it needs, the vasculature is coupled to that neuronal increase in activity and vasodilates in order to accommodate more blood to that area. So in a normal state, there's constant blood flow. However, when there is a decrease in regional cerebral blood flow, i.e. when there is an infarct or a stroke or something like that happening, you get cellular compromise of cellular integrity and neuronal function. And remember, because the brain is so highly reliant on oxygen as well as glucose, those run out very quickly. And if you're not using a backup like fat or something like that, if you can't undergo anaerobic metabolism, which the brain can't, you become ischemic very rapidly when there's a drop in regional blood flow. What does that then lead to? That then leads to an infarction zone, firstly, okay? And that infarction zone is where there is localized tissue injury with hypoxia, tissue death, cell death, and leakage of particularly potassium and hydrogen ions. But surrounding that, there is what we call the penumbral zone. And what that is that is an area around the infarct that is still perfusing, but is ischemic. It is not infarcted, it is not dead yet, and that is potentially salvageable. So if you have a look at that over here, as we look at this image, we see that we have a central zone of infarct over here, where at this core, there is basically no brain tissue. There is no blood flow in this area over here, okay? Then around it, over there, is the ischemic penumbra, that area that I described to you as being at risk. It is very hypoxic, very ischemic. And then even surrounding that is an even greater area of oligemia, so-called reduction in blood flow. And what does that do, or mean, should I say, is that means that that area of brain is potentially salvageable if we do the right things. So the regional blood flow in that area decreases significantly, okay? The CMRO2 is still normal because those tissues are still alive. And so therefore the oxygen extraction fraction, the EF, increases to 50%. But that's about as much as oxygen as can be extracted from the cerebral vessels. So that becomes an issue. And it's this ischemic penumbra that we need to try and protect when patients are coming to the emergency room with evidence of an ischemic stroke. Okay. So how is cerebral blood flow regulated? There's multiple mechanisms. The three of which that I'm going to discuss here predominantly is number one, something called the myogenic response. Number two, there are endothelial contributions, okay? And number three, there are metabolic mechanisms. So let's look at the myogenic response first. So the myogenic response refers to an intrinsic principle of vascular smooth muscle. So I'll say that again. When we're looking at regulation of cerebral blood flow and we're talking about the myogenic response, that means that it's an intrinsic property of muscle in the vasculature smooth muscle. What does that mean? Is that as the pressure in the vessel increases, okay, the vessel will contract or constrict in response to that to reduce the cerebral blood flow. So if we then remember the Hagen-Purcell equation and the relationship between pressure, radius, and blood flow, okay, when the pressure in a vessel increases, the flow will increase. So the natural response of the arterioles with no other input from anywhere else, it's an intrinsic response to that vessel wall. It will constrict immediately to reduce cerebral blood flow to protect the brain from an increase in pressure. By the corollary, the same opposite of that, if there is a drop in pressure, okay, if there is a decrease in blood flow, the vessels will dilate to accommodate more blood to try and increase cerebral blood flow. And that is maintained by the myogenic tone and the myogenic sensitivity of the vascular smooth muscle. So that's number one, the myogenic response. Number two, there is significant endothelial contribution. The main one is nitric oxide. And if you remember back to physiology, L-arginine is converted by nitric oxide synthetase in the endothelium, NOS, to nitric oxide. eNOS, this is expressed massively in the endothelium. And so the endothelium itself, remember this glycocalyx that we were taught about, that produces nitric oxide from L-arginine through the actions of nitric oxide synthase. Then nitric oxide will cause vasodilation and vascular smooth muscle dilation. There is then endothelium-derived hyperpolarization factor, EDHF, and it is hypothesized that this helps with compensatory vasodilating mechanisms in the brain. And then remember, the brain produces eicosanoids, and the brain has got very active arachidonic acid metabolism. And so vasodilators, such as prostacyclin, PGI2, prostaglandin E2 and D2 epoxygenase in the epoxygenase pathway will cause vasodilation. And then vasoconstrictors are also produced by the eicosanoids, prostaglandin F2 alpha and thromboxane E2. So the brain vasculature itself is very, very active at a myogenic level by intrinsic responses and at an endothelial level. The third metabolic mechanism is is metabolic, that maintains cerebral blood flow, and this basically maintains cerebral metabolic demand. So as the brain metabolizes oxygen and consumes glucose, metabolites are released in response to an imbalance between oxygen demand and oxygen supply. So when tissue demand increases above oxygen supply, then metabolites are released, predominantly carbon dioxide, potassium hydrogen ions, oxygen hydroxyl ions, adenosine, and this causes an immediate local vasodilatory response. So the metabolic mechanism, just to say again, is as the brain tissue consumes oxygen and glucose, and it's not receiving enough blood in an area, there will be a buildup of potassium, hydrogen, of CO2, of lactic acid, of hydroxyl ions, etc., oxygen-free radicals, and that causes an intrinsic vasodilatory response. And by the same token, as there's a lot of blood being flushed in and there's very little metabolites being formed, there will be a vasoconstrictory response. So that's the metabolic mechanism. So just to run through those three again, you've got the myogenic response to control cerebral blood flow, whereby the muscle relaxes and contracts in response to pressure. You then have the endothelial, predominantly dominated by nitric oxide, but also importantly, the arachidonic acid pathway metabolites, the prostaglandins and prostacyclins, which are the vasodilators, and then the prostaglandin F2 alpha and the thromboxane, which are the vasoconstrictors. And then the third mechanism that controls cerebral blood flow is the metabolic mechanism, whereby as tissue consumes oxygen and glucose, and there is a buildup of metabolites, carbon dioxide, free radicals, potassium, hydrogen, you then get a compensatory vasodilation so that you get an increase in cerebral blood flow to wash those metabolites away. And then the opposite also happens if there's a lot of blood flow but little activity, and you've got very low numbers of those metabolites in the blood, low concentrations, you will get a compensatory vasoconstriction to reduce the unnecessary blood flow in that region. So the next concept that I have mentioned before that we need to talk about is cerebral autoregulation. So first of all, what is the definition? So the definition of autoregulation anywhere is the ability of an end organ to maintain a constant blood flow through a wide range of mean arterial pressures. So I'll say it again. The definition of autoregulation for any organ is the ability of an end organ, meaning in this case the brain, to maintain a constant flow regardless or through a wide range of mean arterial pressures. Okay, so what this means in practice is that in a normal patient, in a normal adult, in a normal brain, if the mean arterial pressure is 50 or 180, the cerebral blood flow measured in mils per 100 grams per minute is constant. And it is only at the very high pressures that cerebral blood flow increases, or at very, very low pressures that cerebral blood flow decreases. And then just remember, guys, this formula will become very, very important. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Okay, but just to state again that normal autoregulation in a normal brain, cerebral perfusion will be maintained between a map of 60 and 160, and in actuality, it'll be maintained pretty well at a map of 50 to 180. So beyond 160 millimeters of mercury, cerebral autoregulation is lost, and cerebral blood flow becomes dependent on pressure. And in this instant, the myogenic response will help to protect the brain by causing vasoconstriction in response to this very, very high pressure and flow. If the mean arterial pressure drops below 60, cerebral autoregulation is lost. But at this low pressure, the metabolic response becomes important, and local release of metabolic factors such as purines, hydrogen, potassium, nitric oxide, prostanoids, histamine, etc., will cause vasodilation and will increase cerebral blood flow. So what it's saying is that even though autoregulation only really works very well between 60 and 160, even if you have a situation where your blood pressure rises above, your mean rises above 160, what will happen is that the myogenic response will cause a vasoconstriction and decrease cerebral blood flow to protect the brain. And again, if the pressure drops really, really low and you get hypoxia in the brain and lots of metabolites, the metabolic intrinsic response will cause vasodilation to increase cerebral blood flow to try and bring oxygen and glucose to the brain. So even if autoregulation is lost, the body still has some mechanisms, but obviously in anesthesia, we want to fiercely defend that autoregulatory curve. If we look at the next concept, how does cerebral blood flow respond to oxygen tension? In hypoxia, you get potent vasodilation. And this happens due to opening of potassium channels, causing hyperpolarization and vasodilation. When the oxygen tension drops below 50 millimeters of mercury, you get a sudden, significant, exponential increase in cerebral blood flow. So the brain is pretty non-responsive to oxygen and to hyperoxia, okay? Cerebral blood flow will decrease and then level off. But the minute you drop below 40 or 50 millimeters of mercury as your PaO2, cerebral blood flow shoots up dramatically, and that is due to this rapid opening of potassium-sensitive ATPase channels, and that causes hyperpolarization. If we then look at the relationship between carbon dioxide and oxygen, this one is critical for us as anesthetists and is much, much more linear. So as you see, PaCO2 has profound effects on cerebral blood flow. PaCO2, as it increases cerebral blood flow in a linear relationship between 20 and 80 millimeters of mercury. So what does that mean? That means that between a end-tidal CO2 or a PaCO2 of 20 to 80 millimeters of mercury, as that CO2 increases, the cerebral blood flow will increase in step with that in a linear relationship, okay? And it's only when the PaCO2 goes above 80 or drops below 20 that you lose this regulation curve. And how is this done? Is that carbon dioxide diffuses into the CSF, it creates hydrogen ions, and that causes vascular smooth muscle dilation and increases cerebral blood flow. This is critical, okay? So manipulating, when we get to the next lecture on neuroanesthesia and raised intracranial pressure, one of the best and quickest ways to raise or drop intracranial pressure is by manipulating carbon dioxide. So it's something you need to be exquisitely aware of. The third thing we're going to talk about, we've spoken about cerebral blood flow now. We're going to talk about CSF. So cerebrospinal fluid, its functions are to cushion the brain against mechanical forces, and it provides buoyancy to the brain so that your head doesn't feel like you're lugging around a big 1.5 kilogram brain. It provides capacitance against intracranial volume expansion. So meaning that if you get an expansion of blood or brain tissue or tumor, you can cushion that by decreasing the CSF volume and therefore maintaining a normal intracranial pressure. CSF facilitates the movement of neuroendocrine substances, so hormones, neurotransmitters. It clears metabolic waste, namely carbon dioxide and lactate, and its predominant role is to provide a homeostatic environment for the brain. So CSF is critically important, okay, in the health of the brain. Excuse me. So the production of CSF, the volume is roughly in an adult about 140 to 160 mils. So it's roughly about 2 mils per kilogram, okay? The rate of production is about 0.4. I use in my mind just easier 0.5 mils per hour, okay? So again, in an adult, they will produce roughly 500 mils per day, okay? Excuse me, 0.5 mils per minute. And a normal CSF pressure, okay, in children or in adults is no more than 10 millimeters of mercury. So CSF is very important, but CSF is great because if you get a big brain bleed and you get swelling, you can rapidly shift CSF out of the brain into the spinal cisterns, and you can rapidly decrease or maintain a normal intracranial pressure. How is CSF formed? Well, if you remember, most of the CSF is formed in the choroid plexus, and it then gets formed in the choroid plexus. It moves into the third ventricle, the lateral ventricles. It then goes down the cerebral aqueduct into the fourth ventricles, and then it then goes down through the median and lateral apertures into the spinal canal. There are extrachoroidal sources of CSF, and most of it, commonly those sources are passive filtration of fluid out of the capillaries, and you can get active secretion across the epithelium. And these are pumps, co-transporters, ion channels, aquaporins, and they are what is responsible for putting sodium, chloride, potassium, bicarb, and water into the CSF. So the CSF predominantly, as we said, formed in the choroid plexus. It then circulates in the third ventricles, the lateral ventricles. It comes down the cerebral aqueduct and goes into the fourth ventricle. So how does CSF flow? It starts in the lateral ventricles through the interventricular foramina. It then goes into the third ventricle via the aqueduct of Sylvius. It then goes into the fourth ventricle and out the foramen of Magendie and the foramen of Luschka, what's so-called lateral and medial apertures. And then it enters the subarachnoid space. So to remember it, liquid inside the cerebrum flows around the subarachnoid space, lateral ventricles, interventricular foramen of Monro, third ventricle, cerebral aqueduct of Sylvia, fourth ventricle, the apertures, subarachnoid space, and then the sinuses. What is CSF made of? Well, it's predominantly water with a low concentration of potassium, calcium, bicarb, glucose, and urea, and relatively higher concentrations of sodium, chloride, and magnesium. How is CSF reabsorbed? Well, remember, guys, the main site of CSF reabsorption is in the arachnoid granulations, which are in the walls of the sagittal sinus. These so-called arachnoid granulations are a one-way valve, and they lead to fluid being drawn from the CSF into the blood. Factors that can impair CSF drainage, and this is important for us, is coughing, straining, or bucking on an ET tube. If there is an inappropriately high PEEP, if the patients have got a dural sinus thrombosis, so there's no blood going through these arachnoid granulations, or if patients are in CCF and there's very, very slow blood flow. So the next critical concept that we need to talk about is the so-called Monro-Kellie doctrine or hypothesis and the volume-pressure relationships in the brain. So what does the Monro-Kellie doctrine say? Well, it says that the cranium is a rigid box, and so therefore the volume is fixed and its contents are incompressible. So what does this mean? It means, as it says, imagine that this, cell phone is the brain, all right? Now, around it here, I've got the meninges and the skull, okay? Then imagine that this big area here is the brain. This central ring, let's imagine that is the CSF. And then this Apple sign here, shout out to Apple for free advertising, is the blood. Now, the Monro-Kellie doctrine says the cranium, the bone, is a fixed vault, okay? It can't expand, it's bone. And its contents are incompressible. I can't squeeze the brain into nothing, okay? So, a change in volume of one of the three, of blood, CSF, or brain tissue, has to be accompanied by a decrease in volume of one of the others in order to maintain a normal pressure. So, if I've got a fixed box and this Apple sign starts getting bigger and bigger and bigger, the blood, I've got a brain bleed. What's the first thing it's going to demolish? The ring, the CSF. It's going to squeeze all the CSF out of the brain into the subarachnoid spinal cisterns to try and maintain a normal pressure. But as the bleed gets bigger and bigger and all the CSF is squeezed, the brain tissue can't go anywhere, and inevitably the pressure will spike exponentially. So that's the Monro-Kellie doctrine. There is brain, there is CSF, and there is blood. And at a normal equilibrium, at a normal intracranial pressure, they are at a volume of equilibrium. The volume of one constituent is compensated for by the volume of another. So for example, when I am sitting now, as I stand up, there'll be a temporary drop in my blood pressure and a temporary drop in the blood in my cranial vault. That will be compensated for by CSF to maintain the intracranial pressure so that I don't get dizzy when I stand up. Okay. What are the normal contents? Well, the brain is about 80%. And then for the maths, it makes my life easier. I've just always said 80% brain, 10% CSF, and 10% blood. So you can see if you get a big brain tumor, for example, okay, and suddenly now you've got 90% brain tissue, you can need to have only 5% blood and 5% CSF. Otherwise, you're going to get an increase in intracranial pressure. So if we put that on a volume pressure curve, what it says is that at a normal intracranial pressure range, okay, of 7 to 15, everything is pretty solid over here, okay? As soon as the volume of one of these components increases past this point, you get an exponential increase in intracranial pressure. So CSF is the predominant compensatory mechanism, okay? What happens is that once the CSF reaches its compliance, its maximum ability to shift out of the brain to accommodate the increase in blood or the increase in tissue, once that you get past that point, you don't get a gradual increase in pressure like you do see in the autoregulatory curve. You get an exponential increase in pressure. And that's where patients can be talking to you, looking fine with a big brain bleed, and they're on the edge. And 10 minutes later, they GCS 3, and you need to rush them to theatre for an emergency craniectomy. So what happens when the pressure raises too high? Well, you get brain herniation. So you get transclival, you get subfalcine, you get transtentorial, upward or uncle, you get tonsillar, and then you get central, okay? So if you look at this next image over here, so if you look here, the subfalcine is where it shifts from one side to the other. Central tentorial herniation is where the brain goes down towards the brainstem. Transcalvarial is where there is a hole in the skull and you get herniation out that. You can get upward herniation of the brain stem, okay? And then the most fatal herniation is downward cerebellar tonsil herniation into the foramen magnum, and that can cause instant death. So guys, we've spoken about general neurophysiology that applies to both adults and children. What is specific to children though, guys? So they have a larger head relative to body size, okay? And then this slide is specific about brain trauma. So they have a lower center of gravity. So when they fall, they're more likely to fall on their head. But they have greater brain water content, okay? So the brain gets dehydrated much quicker. They've got much greater cerebral blood flow, oxygen, and glucose consumption. So they are significantly at risk for hypoxic brain injuries as well as for hypoglycemic brain injuries. And they have got ongoing myelination and synaptogenesis. So their brains are very active, but thankfully for us, it means that their brains are very neuroplastic. Now, we'll talk more about neuroplasticity later on in this podcast, but just briefly, neuroplasticity refers to the ability of the brain to heal and reform new synapses and new neurons in response to an injury. So that's why kids who have major traumas or major tumors or brain injuries or brain surgery, they end up doing so well because of this increased myelination and synaptogenesis. So what's important for us to understand when it comes to neonatal and infant autoregulation is that neonates have got significantly impaired autoregulation. And in reality, neonates can probably only autoregulate their blood flow at a mean arterial pressure of around 30 to 40 millimeters of mercury. Above that, you're going to get a significant increase in cerebral blood flow. And below that, you're going to get a significant decrease in cerebral blood flow. We don't really have predictive tools for monitoring what happens to infants and neonates' autoregulatory curves, but I just use the sort of standard motto that it is impaired. So if you have a neonate or if you have an infant, so anyone under the age of 1 year coming for neurosurgery, but coming for any surgery, keep in mind that their autoregulation in their cerebral blood flow is very pressure dependent, much more pressure dependent than an adult. The other issue that we have to be aware of is that they have a very different blood-brain barrier. So if you look at the CSF brain barrier, there are wide junctions between the cells and there are gaps over there, okay? There are gaps in the blood-brain barrier endothelial capillary cells. There is a large gap between the basement membranes of the blood CSF barrier. And then on the outer CSF barrier, the cells are only very loosely attached to the basement membrane. So what that means is that neonates and infants have an impaired blood-brain barrier, so they are much more sensitive to the central nervous system side effects of all drugs, and in particular, our anesthetic agents and our opioids. The next issue that we need to keep in mind is the risk of neonatal intracranial hemorrhage. So what are the causes of neonatal ICH? Most commonly is prematurity related and then infection related. However, there are then trauma and iatrogenic related, and this is where we come in. So there used to be fairly barbaric practices, in my opinion, in children, whereby premature infants were thought to be too unstable, too unwell, and as such, they were intubated awake. And that stress, or the stress of painful procedures being done on them, when it was thought that these neonates couldn't feel pain, would cause such a stress response and a shoot in their blood pressure that it will rupture the very fragile cerebral vessels that are at the junction of the gray and the white matter. Now, obviously, we don't do that anymore. I hope ever, anywhere in the world. We give them an anesthetic, you induce a neonate, you paralyze a neonate just as you would anyone else. But the other thing that's very important, and we'll get to this when I discuss anesthesia for premature neonates and NEC, what's critical is that these cerebral vessels at that bridge are very fragile, not only to spikes in blood pressure, but they are fragile to swings in blood pressure because they don't have that nice muscular layer around them. They're very, very thin, sometimes only 1 or 2 or 3 cell layer thick capillary. And you imagine if you then get an increase in blood pressure, you get a big increase in blood flow. Then you drop the blood pressure, you get these collapse and you get no blood flow. And that opening and closing can cause them to burst. So it's not just high pressures, but it's swings in blood pressure that can cause an intracranial hemorrhage. It can also come from a bleeding diathesis. It can come from congenital brain tumors, non-accidental injuries, God forbid, and then genetic. But the most common ones we will see will be prematurity related, infection related, and as I say, hopefully not, but it is still an issue, iatrogenic related intracranial hemorrhage. So lastly, guys, anesthesia and cerebral blood flow. What do inhalational agents do? Well, number one, inhalational agents decrease cerebral metabolic rate of oxygen consumption and they decrease cerebral glucose consumption. However, they increase cerebral blood flow, as you can see on this graph over here. So, as anesthetic dose increases, okay, cerebral metabolic rate decreases. All right. But cerebral blood flow increases. Why is that? Because volatiles, they cause cerebral vasodilation, just as they do cause vasodilation throughout the body. So you get a decrease in oxygen consumption, a decrease in glucose consumption, but an increase in supply. So they are protective to the brain. Volatiles are, okay? So here is a summary of the effects. Sevoflurane fairly significantly increases cerebral blood flow, decreases cerebral oxygen consumption. It does cause some inhibition of cerebral autoregulation. The reactivity to carbon dioxide remains normal. Isoflurane, often described as the ideal inhalational anesthetic because it doesn't significantly increase cerebral blood flow. Desflurane increases cerebral blood flow. Nitrous oxide increases cerebral blood flow. But in comparison to carbon dioxide, none of the volatiles will affect cerebral blood flow as much as carbon dioxide. So don't get worried when people say, oh, you mustn't use volatiles for neuroanesthesia. We'll talk about that in the next, very next episode. Volatiles are perfectly safe. You use carbon dioxide to manipulate cerebral blood flow and intracranial pressure up and down as you might need it. And remember that at a MAC of 0.8 to 0.9, these effects on cerebral blood flow and cerebral autoregulation are very limited. So as long as you don't have a patient very deep on their volatile, they will be fine. What do the induction agents do? All intravenous induction agents maintain flow metabolism coupling. So what does that mean? It means that as I give you propofol, thiopentone, dormicum even, or etomidate, it not only puts you to sleep and decreases your CMRO2 and your glucose consumption, it causes a decrease in cerebral blood flow as well, which means that they decrease intracranial pressure much more effectively than the volatiles. Propofol in particular causes a significant decrease in cerebral oxygen consumption and blood flow, but it still maintains a so-called enough, what is the word? I want to say like Goldilocks. You have enough of a buffer of cerebral blood flow, but your intracranial pressure drops. Ketamine is the exception. It was thought for many, many years that ketamine increases intracranial pressure. That is shown to not be true. Ketamine increases cerebral blood flow, okay, but it does decrease cerebral oxygen consumption. But by maintaining a normal blood pressure, ketamine is an ideal drug in trauma patients to maintain a normal cerebral perfusion pressure. So if we look at the intravenous anesthetic agents and how they affect, you can see that all of them decrease cerebral blood flow. They all decrease oxygen consumption. They have pretty limited effect on autoregulation. They have limited effect on carbon dioxide reactivity, but they decrease intracranial pressure. And as you see, propofol and the barbiturates do it the most, opioids the least. Dexmedetomidine, Precedex, the alpha-2 agonist, is a unique case. It beautifully decreases cerebral oxygen consumption. It decreases cerebral blood flow. However, just be aware of the sedative effects. I know that it's not said to be a respiratory depressant, but remember, neurosurgery, opioids, and Precedex, there is a risk of your patient retaining CO2 and increasing their intracranial pressure. So just keep a thought out for that. What about muscle relaxants? They have minimal to no impact on cerebral blood flow, cerebral volume, or cerebral or intracranial pressure. Pancuronium may cause issues, but we don't use it anymore. And the histamine releasing ones, I don't even use anymore. I use rocuronium, and that does not affect intracranial pressure. And then just remember the stories about succinylcholine, okay? It is much better to give a patient succinylcholine, scoline, and let them fasciculate and have a brief increase in intracranial pressure than you to intubate them not fully paralyzed and they cough and gag and they quadruple their intracranial pressure. Sux is not ideal, but it is not contraindicated when you need to rapidly secure the airway. Vasoactive agents, so your noradrenaline, adrenaline, phenylephrine, etc., okay? Generally, they do not affect cerebral oxygen consumption. They can affect cerebral blood flow as they impact on mean arterial pressure and cardiac output, okay? Their direct effect, though, on the cerebral vasculature is limited. So if you look at this graph over here, it's very busy, but basically it shows you what sodium nitroprusside and all of these vasoactive drugs do. And as they do in the body, they do in the brain. So sodium nitroprusside will decrease blood pressure. It will cause vasodilation. Whereas adrenaline, noradrenaline will increase cerebral blood flow, will increase cerebral oxygenation, but will also increase intracranial pressure. So guys, what is the take-home message? Just a reminder, the brain is about 2% of an adult's body weight. It uses a hell of a lot of oxygen, 20% of total body energy consumption. In an adult, about 3.5 moles of oxygen per 100 grams per minute. In a neonate, it's about 7 moles of oxygen. In an adult, 5 milligrams of glucose is consumed per minute. In a neonate, it's about 10 milligrams. Cerebral blood flow in an adult and a neonate, it's about 1/5 of cardiac output. Intracranial pressure should be 7 to 15 in adults. It should be no more than 10 in neonates. Pathological raised intracranial pressure in adults is greater than 20. In neonates, it's greater than 15. Intracranial cerebrospinal fluid volume is roughly 150 mils, and it's produced at roughly 0.5 mils per minute. So guys, that is neurophysiology relevant to the anaesthetist, both for adults and kids. I hope you enjoyed it. Our next episode tomorrow will be pediatric neuroanesthesia, where we are going to discuss very simple VP shunts, and then we're going to discuss very complicated large tumor repairs. This is a very big topic, so there's going to be an extra talk on scoliosis repair, and then there's going to be an extra talk on craniosynostosis and craniofacial abnormalities. Those extra talks will be exclusive to subscribers, so there are very, very big things coming. I've got a huge announcement tomorrow, guys, that I'm going to be making on TikTok, YouTube, and everywhere. Very good news, my camera has arrived, my lights have arrived, so this is the last episode you will be seeing me on this terrible camera, but thank you to my webcam, it has served me well, Thank you to the Dr. Tristan Anesthesia Tutorials community. Your support, your feedback, everything has been overwhelming and life-changing. And let's learn together. Let's grow this channel together, and stay blessed. And I hope you enjoyed this. Let me know what you think in the comments. And remember, like, share, and subscribe, guys. Have a wonderful, wonderful evening. Cheers.